Good morning, everyone. I want to add my welcome to you all as new faculty to Johns Hopkins Medicine, and to tell you that the years go by quickly. It wasn't too long ago, it feels, that I was sitting in your position, and it really is a privilege to be at this institution. And I think what people have emphasized is really not, it's not pie in the sky. You can chart a stellar course and establish a phenomenal career at this institution. And for those of you who are just joining the faculty, I think the presentations this morning have really spoken to the rich history of this institution, the first graduate medical institution in the United States that had equal admission for women on par with men. And over the last 125 plus years, Johns Hopkins has defined and set the standard for the tripartite mission of academic medicine: research, teaching, and patient care. And I came to this institution 20 years ago to do my vitreoretinal surgical training. I'm a professor in ophthalmology at Wilmer. And during that time, I have witnessed an evolution in the philosophy and a renewed commitment to patient care as the most fundamental part of this tripartite mission, the part that I think supports the dome for research and teaching. And while the challenges of balancing a busy clinical schedule with conducting impactful research and training the next generations of physicians has never been greater, believe me, we know what the challenges are. For the 20 years that I was here, almost 20 years, I saw patients 3 full days a week, more than 100 patients a week, did surgery all day on Wednesday, and at night and weekends. That's when I did my clinical trials work, and you put your presentations together and your publications together. So we know the challenges that people have as clinicians. But I'm here to speak to the fact that I think there has not been a better time than now to be a clinician at Johns Hopkins. So an example, created in 2006 with a generous gift from a patient benefactor, the Miller-Coulson Academy of Clinical Excellence at Johns Hopkins was established to recognize and to reward excellent clinicians, just as excellent scientists are rewarded for their research. The Academy's mission has been to define clinical excellence in an academic setting, to develop systematic means of measuring it, and to recognize the clinicians who provide excellent patient care through their mastery in communication and interpersonal skills, professionalism and humanism, and negotiation of the healthcare system. Johns Hopkins recognizes these clinically excellent academic physicians for their diagnostic acumen, knowledge, scholarly approach to clinical practice, and importantly, for their passion in patient care, all of which they model for their medical colleagues, trainees, patients, and staff. The Miller-Coulson Academy has been going strong and has just about 100 members now, and has really become a core representation of what clinical excellence is at Hopkins and actually beyond Johns Hopkins. Another example of why it's a great time to be a clinician. Established in 2007, the Institute for Clinical and Translational Research at Johns Hopkins, an NIH-funded entity, has a mission to translate basic science discoveries into clinical research and to translate clinical discoveries into the community and to communicate these experiences from clinical practice back to researchers. The ICTR is uniquely poised to assist clinical investigators with their challenges in planning studies, in regulatory support, conducting studies properly, recruitment, informatics and biostatistics, and community collaboration. And I believe you're going to hear more this afternoon from Dr. Ford, who's the head of the ICTR at Johns Hopkins. And these are just a few examples of recent publications that are the culmination of clinician investigators participating in team science and community partnerships under the fertile umbrella of the ICTR. Now, before providing another example of how Johns Hopkins values and supports its clinicians, allow me to provide some contextual background, and Dr. Oliva Hemker mentioned this already. For all of its 125-plus year history, Johns Hopkins has had a single promotion track with common elements required for faculty advancement, namely excellence in scholarship and impact upon one's field. And while a variety of career pathways have existed in this scholarship or traditional track, such as clinician educator or researcher program builder, clinicians were historically promoted more slowly along this pathway because of the inherent obligations that we have seeing patients, doing surgery, and still having to find time to travel, put together your projects and your talks, and to promote your career. So when a 2017 faculty survey unearthed discontent among clinicians over the time to achieve academic success measured in terms of promotion and tenure compared to their colleagues who, for instance, strictly supported the research mission at Hopkins, Hopkins not only listened, but evolved. In 2019, a clinical excellence pathway for promotion was proposed and spearheaded by Dr. Cynthia Rand. I believe you're going to hear from her later this afternoon as well. And it was approved in 2020. And the clinical excellence track, I'm proud to say, has since promoted dozens of faculty to associate and full professors, people who had been on faculty for decades without having had promotion. So I'd like to briefly introduce you to the clinical excellence track, which I have the privilege of co-chairing with Dr. David Hellman. To be eligible for promotion along this track, faculty must devote at least 60% of their effort to patient care, and leadership or administrative efforts that directly relate to the delivery of clinically excellent care, including clinical supervision and teaching learners, can contribute to this 60% effort. Candidates are promoted for their sustained clinical excellence, and they must demonstrate sustained clinical excellence at rank and have either a regional level of recognition of clinical excellence within their field to be promoted to associate professor, or national recognition within their field for clinical excellence to be promoted to professor. And in addition, candidates for associate professor must be judged by peers to be in the top 25% of clinicians in their field, and people who hope to ascend to professor in this track must be recognized as being in the top 10% of clinicians in their field. So there are 7 total criteria by which candidates are assessed, including clinical effort and excellence, measured, for instance, by clinical draw to the institution. Are people coming to see you not just because you're a Johns Hopkins faculty member, but because you're the premier expert in pediatric inflammatory bowel disease or whatever your profession, your clinical interests are? Have you received awards for clinical excellence within the institution or by your professional societies within the nation? Another criterion is clinical performance and contribution. Program building, leadership within the institution, leadership within your professional societies. A third criterion is recognition of clinical excellence as documented by letter writers, both within and external to Johns Hopkins, people who write your letters of recommendation for promotion. Teaching and mentorship is an important criterion, as is discovery. And discovery can be demonstrated through typical venues, such as peer-reviewed publications, participation in clinical trials, participation in patient registries, patient recruitment, contributing biospecimens, or contributing in other ways to team science as a clinician. Dissemination is an important criterion, and that's through clinical guidelines papers, team-based research, community education, public health advocacy, and finally, institutional contributions. So similar to the traditional or scholarship track, the clinical excellence promotion track portfolio consists of a nomination letter from your department director, your academic curriculum vitae, and a list of internal and external letter writers from peers and leaders who can attest to the candidate's clinical excellence either at a regional level or at a national level. And an aspect that's unique to the clinical excellence track that the scholarship or the traditional pathway does not have is a 360-degree survey. So this is a survey for which the candidate will submit approximately 30 names and contact information for participants, including peers and leaders in the respective field, staff, learners, trainees, patients, and family members who can attest to the candidate's clinical skill, knowledge, acumen, communication, collegiality, professionalism, and reputation compared to other clinicians in the field. The pathway with this 360 survey mirrors what Miller-Coulson has done, and it's been validated. And in fact, they send these surveys, the CV, and the departmental letter outside the walls of Hopkins to get evaluations from referees who then support the promotion. Commonly asked questions by people when they learn about the clinical excellence track: is the clinical excellence promotion track considered a tenure track? And the answer is yes. So just like the traditional or scholarship track, colleagues who are promoted along this track are promoted and attain a tenure as professor. Are junior faculty hired on a specific promotional track? The answer is no. Early on in your career, as Dr. Oliva Hemker alluded to, it's important to, find your focus and to decide what you think your clinical and your research interests are. And typically that will determine whether you want to pursue promotion along the scholarship track or along the clinical excellence track. But we're all in academic medicine, and we know that sometimes your passions and your interests and your efforts change. And if people have a change in career where you were grant funded and later in your career you become more of a clinician scientist or a clinician investigator, and your percent effort changes and it makes more sense to go from the scholarship track to the clinical excellence track, that can occur. Nobody's going to hinder that transition, and the alternative switch can occur as well. But we anticipate that most people, once they seem to declare themselves on a particular track, would likely remain on that track. Once faculty are promoted on a specific track, must they stay on that promotional track? And the answer, as we just discussed, is no. Promotion on the clinical track requires evidence of sustained clinical excellence. What does sustained mean? So just as with the scholarship track, there's no set term limit or time limit for promotion. So you don't have to be at rank for a minimum of X number of years before you can go up for promotion. But from what we've seen with the candidates who've come through, and our anticipation is that it probably takes a minimum of maybe 4 to 5 years to demonstrate sustained clinical excellence at rank because of the criteria of having to disseminate and build a reputation and to develop clinical draw. Is the clinical excellence track appropriate for non-MD clinicians? And that's perhaps one of the more rewarding facets of this pathway. We have seen speech pathologists who are recognized nationally be promoted in this pathway because they work with ENT divisions and they're instrumental in the division. We've had psychologists and audiologists and physical therapists become promoted on this pathway. So the pathway speaks to scholarship and clinical excellence, but not necessarily the traditional MD route for promotion. Is the clinical excellence track appropriate for clinicians who do not provide direct in-person or patient care? And the answer, again, is a resounding yes. So for instance, our colleagues who are pathologists and perhaps have no direct patient care, or radiologists, and have been promoted, of course, along the scholarship track, but may find that because of the type of work that they're doing, that this may be a more suitable track for promotion. And finally, how long is the promotional review process for the clinical excellence track? Well, currently it mirrors the typical traditional scholarship track, about 6 to 12 months for associate professors to be fully evaluated and promoted, and 12 to 18 months for full professors to be evaluated and promoted. Currently, because it's a new pathway, and we want to make sure that the metrics are calibrated to what's been done in the scholarship track, the method is that once the candidate submits his materials, and most departments have an internal review process that prepares the candidate for promotion, and the candidate's only put up by his department once he is approved or vetted by the internal promotions committee. Then the packet goes to either the clinical excellence track, and we assess candidates who are going up for both associate professor and full professor, or to the traditional scholarship track where candidates are going up for associate professor or full professor, 2 different committees for those. Currently, our candidates who are approved by the clinical excellence track are still presented formally to the associate professor promotions committee or to the professor's promotions committee as a formality before going to the advisory board of medical faculty. That may change in the future, but because it's a new track and because we wanted to have calibration and for people to sort of understand exactly what the candidates' portfolios look like before they go to the ABMF, that's the current system. So this has just been a very brief introduction to what the School of Medicine has to offer clinicians. I hope I've successfully convinced you that there's no better time to be a clinician at Johns Hopkins. And I want to thank you for your attention and to wish you the best of luck as you start your careers here. Thank you.